Okay. So if you have any question during my speaking, just I'm just muting you. All right, so just stay muted until finish talking, because I want to go fast, and then we can discuss the topic. And after that, I need someone to do the station itself or similar one, just to fix it in our brain before we move on. All right, so let's start with this intestinal obstructions. So actually, I chose this topic because it was I found it last day on my second job in the NHS. So I I just finished my job last Friday, and this is one of the patient. I work in acute medicine, but this is one of the patient, and I thought I should just write down what exactly happened to this patient and what happens in the book, Oxford book I teach you from. So if there is any different at all in the real life than what we read from the book, so obviously there is no any difference. So when I wrote it down, I found it exactly as in Oxford medicine book. All right. So any patient, history of present illness, we need to ask open question. Just how can I help you? May I know what brought you to the hospital? Let them tell you everything they have. So we normally tell you the symptoms they're having now, 2 or 3, and we will elaborate all of them. And like if the patient started with any symptoms according to any systemic review, like as I said, doctor, I have abdominal pain, for example, or I have vomiting. So try to, can you tell me more about this? Let them tell you more, and then elaborate it. If it is pain, we do Socrates. Anything else, we do Odibara, like just we omit some few questions from Socrates, obviously. And then abdominal, like he told you, for example, I have abdominal pain. You ask him anything else, he said no. Or like what doctor, sometimes they say like this, they don't make your life easy. Sometimes they tell you in the exam. So if they said like what doctor, so if the pain in the, for example, gastrointestinal system, so yes, we need to ask the symptom related to this first, like abdominal pain. So we'll ask any abdominal distension, any vomiting, any constipation. So when you ask these symptoms, actually you are very specific doctors without knowing this intestinal obstruction, but you just review the symptom system, but still you are in the right track. Like because the GMC examiners get irritated when you be off topic. Like some people get 0 and 1 in data collection. Why? Because just they ask question randomly. They don't like this. So but the thing make your life easy, just start with open question. What brought you to the hospital, or how can I help you? And then can you tell me more? Before you start anything, just can you tell me more about it? And the third question, anything else? So this is your approach in all history-based stations. Ask these questions. Don't rush to start your duty, because you will be knowing what you will know, not like it. You will be like sometimes off topic, and sometimes you will ask lots of questions, which will waste your time. But when you guide the patient to tell you what they have in their head, your life will be very easy, and you will make less effort, less time, but you will get the right things. Because in the exam, they're expecting you to get everything in the script out of this role player head. So how you can do this? Just with open question. Can you tell me more? Anything else? Do you have any concern before I move on? So always make this your approach. And so the patient said abdominal pain. So we have pain here. Don't forget your Socrates. And speaking about Socrates, also some doctors find it challenging to remember, like what question should I ask, especially if the patient told you few of them, like tell you, I have abdominal pain since yesterday and it's getting worse, and it's really, really bad. So he told you some of Socrates, but what I do normally, because in the exam with the stress, you will forget what the patient told you, or it's difficult to fit which being answered already and which not. So just I will repeat again. So he told you I have abdominal pain, or I have tummy pain, but the tummy is too big. So can you tell me where exactly the pain is? So I'm going in order again. I'm asking the same question, where exactly, but I'm not repeating, because instead of can you tell me where is the pain, because he said pain in my tummy. So where exactly the pain is? So I need a specific place. And does it go anywhere else? So we have two questions for where. Where exactly does it go anywhere else? And then onset, or when did it start? How did it start? Has it changed since it started? So this is three questions, and I keep repeat the word start again and again and again in these three questions. So I also remember it by this. Just when I say start, how did it start? When did it start? Has it changed since it started? So I have this three start. So it come to my head quickly before, without thinking like what I missed, what should I ask next in Socrates? Because Socrates, if you think inside your head what next to ask, it will take 2 minutes, and the history needs only 4 minutes. How you gonna finish your exam and just asking Socrates alone in 2 minutes? So so that's why you have to learn Socrates by heart, and the question has to be spontaneous, quickly, fast. And so two questions for where, three questions has a start on them for the onset, and then two questions for is there. Is there anything that makes it worse? Is there anything makes it better? And could you please? I asked two questions for could you please tell me where? Could you please score the pain for me? And what else? I forgot other good. Describe, yeah. So we have character, we have the severity. Could you please score the pain for me? Could you please describe the pain for me? And then we have associated symptoms to finish with. Alongside this pain, do you have any other symptoms? And after that, I will ask anything else. I finish elaborating the pain, anything else. So it has to come quickly, learn it by heart, do it so fast so you can move on to the next. This is really helps you to manage your time, because there is some issue in history-based station about time management. So, but when you know them by heart, you know what to do. It wouldn't take such a time. And also uh, interpersonal skills, acknowledge whatever, anything they're telling you, I have abdominal pain. Before you start, can you tell me more? I'm really sorry. I can see that this is very stressing for you. Don't worry. I will give you some painkiller, but if you don't mind, can you tell me more about it? So always acknowledge their feeling and then continue with the medical part. And so also he has a vomiting. So vomiting, when we ask about vomiting, we ask when did it start? How many times did you vomit? We'll ask amount as well, and content and color, and most importantly, any blood. So also, because like just as a junior doctors, you have to be able to elaborate what the patient telling you. So that's why you have to be prepared for this. Like if you didn't master your history yet, take time to master it, because if you have perfect history, still they will try to pass you regardless of medical knowledge, because here in this country medical knowledge is not really important, because you will have some senior with you. You need the basic knowledge or basic steps, especially ABCD approach, like just to stabilize patient before the senior come. But extremely important to know how to ask history, because this is just our job as junior doctors. Okay, so we also, because he has gastrointestinal symptoms, so we also ask about melena, and we suspect intestinal obstruction here from the symptoms. So we ask about, did you pass any wind? Because if there is no wind, it means complete intestinal obstruction, an emergency. But regardless if he passed wind or not, abdominal pain and vomiting, we have to rule in intestinal obstruction, so it's emergency situation. So we have to prepare the patient for surgery as well, because we know intestinal obstruction, it could be conservative treatment, but it could be also surgical. So when you think there is possibility of surgery, always kneel by mouth and start preparing the patient blood and these things. So we will ask cancer symptoms. In this station is very important, because if the patient had intestinal obstruction, it could be due to tumor, for example. So that's why we ask about fever, nights, weight, appetite, and lymphadenopathy. And we finish the station after we ask do you have any other symptoms before you move on to the past medical history, or have I missed anything? I haven't asked you if you asked your DD here, but even like if you didn't ask too much DD, still they will not penalize you in your data gathering, because you finish elaborating what the patient told you, and you ask the patient, you reviewed the system, like systemic gas review, where the patient initial symptom, for example, abdominal pain. Sorry, ask me in the end, please. Yeah, so just write it down. I will answer now if you think you will forget. Yeah, sorry. So you ask them, like they came with some symptoms. You ask, can you tell me more? First, you ask, can you tell me more? The second thing, you ask anything else, and you keep asking this anything else. If like he told you something, elaborate it, and then ask again anything else. But sometimes in the exam, they don't tell you when you ask them anything else. It depends on the role player. Some of them tell you, some not. If he didn't tell you, still you have to ask more symptoms for your DD, but don't stress yourself with knowing exactly what could be the DD. Just do systemic review. Like if the patient came with gastrointestinal symptoms, cover that system, and then ask some few other questions, but always add cancer symptoms, add flu-like symptoms. It's always relevant in most of lab 2 stations, cancer symptoms and flu-like symptoms. And also, like if you stuck and you don't know what to ask by location. Also good trick. Like for example, the patient came with chest pain. So in the chest we have the lung. So you can ask cardio and respiratory symptoms here in this area. Came with abdominal pain. You can ask about the abdomen, also urinary tract, and if female, like pelvis and these symptoms. So I believe it's very easy. Trust me, you don't need, you will get more marks in data when you don't be obsessed about DD. Just do system review this system, and if you can add more few system, like if relevant things, you think they are relevant, you need to add cardiovascular or respiratory, whatever, like just any cough or shortness of breath after you finish abdominal, by any chance any cough or shortness of breath, any urinary symptoms like this, you finished systemic review. Because even like here as a medical student, when they finish the ideal thing is they do, when they finish reviewing the system, in the end of the data, like in the end of the interview, after the examination, they do systemic review. Yes, this is what they do. But sometimes I feel it not, for me, I don't go with it. Like I don't do a systemic review in the end of the station, but I can do it just before past medical history, quick systemic review, but don't stop. And when you practice, you will find it easier, like what to ask, what not to ask. But it's really important to don't complicate your life, and don't be obsessed about asking all the DD in the world. Yeah. Because examiner as well, they don't have tick list for DD, but they have tick list for organization. So always and asking relevant questions. So just make sure what you ask is relevant ask, rather than obsession about making perfect history. So we will ask past medical history. This is for all the station, learn it by heart. It has to finish in just 30 seconds. Have you had any similar medical condition? Have you been there? Have you had any similar problem in the past? Yeah, before you start, do you have any medical condition? Just any similar problem in the past, because if it happened before, it make your life easy. And this, like this patient I told you about, he has intestinal obstruction. This is the third time or fourth time came with exactly same problem, and he knows to have partial intestinal obstruction. So it makes your life easy when you ask the patient, have you had similar problem in the past? He will tell you, he will guide you through the diagnosis, make your life easy. And have you been diagnosed with any medical condition? Are you taking any medication? any allergy, even if you don't want to ask the long sentence, just any medication, any allergy, just to save you more time. Have you been admitted to the hospital before, and any surgical procedure, and any family history of any significant medical issue. So you can, when you learn it by heart, it goes very fast, this part, I believe. So that's why we have to spend around 4 minutes maximum in our history, because we only have 8 minutes. And we have examination, investigation, management. We have to explain management, and it's really long, and addressing concern. So, all right. So idea,
Dr.
concern,
Afag,
and yeah, 1 second. Idea, concern, and expectations. Just before the past medical history, this is the best place to put, because if they brought any concern, you can continue elaborating your symptoms here. Okay. And sorry, Dr. Naim, just give me 1 second, because me normally, if I interrupt it, I forget. So that's, I will finish, and then we can discuss it all from the start. I will start again, okay? So examination, all stations, we will do vitals. And here specifically, we look for evidence of dehydration or shock, because if he vomits, so we will have dehydration and shock. And we do abdominal examination, and we will look for any surgical scars, any tumors, and the rectal examination is important here. All BLAB 2 stations, we will do investigations. Basics 1, full blood count, UNE, liver function test. These 3 ones, full blood count, UNE, liver function test, we do it routinely in the hospital for all patients, full blood count, UNE, liver function test, any patient admitted to the hospital. After that, we will do clotting, group, and safe, because we're expecting surgery here. That's why we're going to do clotting and group and safe for this patient. We will do glucose and amylase. Patient coming with abdominal pain, we need to exclude pancreatitis. Arterial blood gases is not routine in all patients, but if the patient oxygen saturation is less than 92, we have to do it, but we don't do it routinely. Or patient come with this respiratory symptoms, we can mention about it. Chest X-ray, abdominal X-ray in this station, yeah, is to see intestinal obstructions, and CT, further image for senior, and we can consider doing ECG. Admission, we know that this patient has intestinal obstruction, so we have to admit. And symptomatic treatment, don't forget, in all BLAB 2 station, the patient came with headache, came with pain, came with urinary symptoms. There is these symptoms before, you know, even if you don't know the diagnosis, you can treat the symptoms. And you don't need to mention the name. Just I will give you some painkiller, I will give you some anti-sickness medication. And this patient, we have to prepare for surgery. So kneel by mouth, we insert NG tube. And if the patient kneel by mouth, we need to give fluid to compensate, because they will not be eating. So we'll give IV fluid. And always when we give IV fluid, we have to monitor input and output in those patients. And refer to surgical team. So now it's done. Dr. Kabir, I'm sorry, let's go back and ask me what you want to ask.
Thank you. It's okay. Afago, sister, what basically happened while I was practicing in the academy, what I used to do, uh, I would just I would just explore the P1 and have just 2 or 3 differentials. I have found so many individuals, they were yelling at me, why don't you ask this thing? Why don't you ask this thing? And I didn't reply them that much, because in my view, I was expecting that, okay, I need to cover all those medical histories. And if I can at least explore the P1 and take at least a minimum, I just take two or three. At best, I take two. It can be sometimes 3 GDs. I don't extend it that much. Is it okay not to have all the differentials? Because I will not be able to cover. That's why I just cut it short. And only, for example, if it is a case of optic neuritis, I would just explore whether it is multiple sclerosis or acute ankylosing glaucoma or migraine. Then I just ask about the trauma, then I just go forward. I have found so many individuals, they will nag at me, they will DL at me, they will tell me where you have to ask this one, this one, this one, or 3 or 4 more DDs. And sometimes I feel like I'm distressed. What should I do in this regard?
Yeah, so you're doing the right things. And even as I told you, like even just if you ask the patient open question, how can I help you? Elaborated anything else, and you didn't ask any DD at all, still you will pass the exam. So, but if you ask all the DD in the world, you will fail, and they will get you very little mark in the data gathering, because it sounds as if first all the scripts they have many DD and all the doctors doing the same. So examiners, GMC examiners aware about that and drop marks because of this, because anyone is scripted. The other thing that they are not expecting you as a doctor, as a junior doctors, to know the patient like this as fast. So how did you know this is could be the DD? Like you picked, for example, even if you ask about 5 DD, there is still more 5. How did you know the first 5
Yes, that's
are
the
the top?
fact. That's just the fact.
Yeah, so just as you said, just go with your sense, with your common sense, because there is something will be very obvious, and especially lab two, the station, they will tell you this station is this one. The patient itself, when you tell, can you tell me more, will give you typical picture, for example, here of intestinal obstruction. I have abdominal pain, vomiting, and constipation, for example. So it can be something else, like your DD is very limited. And even just if you reviewed the symptoms, you system here, like GIT. So you ask about what else about urinary symptoms, any bloods, melena and vomiting blood. So you finished already. You finished all the DD, regardless what the DD could be. Is it colitis, ulcerative colitis, whatever? So no more. So just yeah, don't follow, because people always expect more from you, because in the script is written more, and unfortunately sometimes even is written in a very bad way, like the patient, for example, in the exam have chronic problem and the DD for acute problem, or the opposite. So don't just follow your common sense as a doctor. So you know the stage, you know basic knowledge about intestinal obstruction, for example, what could be the reason. So just few DD, you are fine. And the less is better. Trust me, the less you ask in lab two, the higher mark will get, because you will focus in the patient concern and expectation rather than just doing lectures in DD for abdominal pain. All right, so you're doing the right
Thank
thing,
you.
don't worry.
Thank you, sister.
You're welcome. Any question from anyone? So in the exams, like some people say, should I say vital? Is it medical term or not? So just even if you said, for me, like what I do, I mention the medical term because this is the thing come to my head quickly. Like I say, for example, I want to do your vitals. I need to do your abdominal examination, your surgical examination. So this is the things come to my head, but I say it and then I explain it. For example, I need to check your vitals, which involves me to check your pulse and blood pressure and temperature, for example. I like to do neurological examinations, which and examinations allow me to see the function of your nerves, for example, and check how strong you are, your power, your sensation. So just explain to the patient, even if you mention the medical term, you have to explain it in simple language. You will be fine. Yeah. Always don't forget to ask permission. Is it okay to examine you? And explain why. Like throughout the exam, I'm doing this and what for. Now I'm asking you this question to have an idea about what's going on with you. So this one, it makes you more professional. You make you get the patient involved in the consultation. You don't just speak to yourself. So always try to involve this kind of sentences throughout your consultation, like and also makes you organized. So now, thank you so much for answering my question. You finish history of presenting illness and you're going to the past medical history. Thank you so much for answering my question. Now I'd like to ask you a few questions to learn a little bit about your medical background. Is that okay? Have you been diagnosed with any medical condition, any medications, blah, blah, blah. So always make it like this. You will sound professional. You will sound getting the patient involved, not like patient-centered consultation, as I said. All right. So in the management in BLAB 2, all of it, think about admit, not admit if you are in a department, but if you are in the ward, for example, of course, we don't need to think about admit here. If they told you this patient is already admitted to the ward. And think the first thing we'll do symptomatic treatment. Before you move on to anything else, symptomatic treatment. And if you know nothing about the station, just symptomatic treatment, you do the right basic investigation, blood one, call your senior. Just I'm going to, we will do like, just don't show them you don't know what's going on or you don't know the station. For example, you tell the patient about symptomatic treatment, and then as I told you, we're going to run some blood tests to find out what's going on with you after the result. And I'm also going to discuss it with my senior. If there is anything more we will do for you. It shows that you are safe doctors and you're getting your senior involved all the time. So it will be very easy. And sometimes, like if you are discharging the patient, so you need to think about safety netting. But don't put safety netting in all the stations, like just a must. For example, this patient is in the hospital. You admitted this patient. So what safety netting I'm going to tell him? I'm not discharging him to tell him about safety netting at this moment. Just the safety netting is just to call the surgical team to come for him and tell him kneel by mouse, but not always necessary to do safety netting, but always think about it, like just symptomatic treatment. If you know the diagnosis or you don't know it, if the patient needs referral, if, for example, you are in the GB setting, if this patient need to be referred to the specialist, and if this patient need to be reviewed by your senior before you refer, and any follow-up appointments, think about it, like just tell the patient like I will arrange another appointment after the results back to discuss it with you further, for example. And in this case, you need safety netting if GB setting, because the patient will go home right now in all GB station, because the patient just come for 10 minutes with you. So all of them going home definitely. So you can give safety netting. And if you stop with the safety netting, just tell the patient if your symptoms hasn't improved, have not improved, or get worse, or you developed any new symptoms, please contact us as soon as possible. So always make it simple, but show them you are safe doctors. Any questions, anyone? You can unmute yourself. And do you have any question?
Hello. On the management,
Yes.
Yes, on the management, there's a point that you stated that CT scan of the abdomen and pelvis is you mentioned in brackets that it's a senior's decision.
Yes.
So now, when I'm mentioning the management, right, then say I'll call my seniors to ask if we need to do a CT scan of the abdomen and the pelvis.
All right. So just I will not even say CT scan of the abdomen. So just I would say just we're going to do an X-ray for your tummy for the patient, and we also I will also call my senior to consider if there is any need for any further imaging.
Okay.
Yeah. So always just keep it open. Yeah.
Thank you.
So just like if you think about this, like all BLAB 2 station, regardless, you know the station, you don't know it. I need to do this bloods basic routine one and explain it to the patient. Like we need, for example, to check your inflammatory markers to see if there is any infection. As I said, even if you mention the medical term, just explain it. But don't say it without explanation, they will drop your marks. But if you explain it, not big deals. And also we'll check the function of your kidney and liver and see if you have any, or you said just the function of your kidney and liver and see if you have any infection. That will be more than enough. So just this, you talk about the initial investigation. As a junior doctor, you shouldn't miss it in all history-based stations. And imaging is not always necessary if you miss them, but when you get to them, just tell, I will ask my senior to consider if there is need for any imaging or not, or to discuss with my senior any further imaging. And this is for investigations. And for sometimes, like some station need specific investigation. For example, say B12 deficiency. This one, dementia station has a thyroid function test. But like say, if you don't remember, I don't think it's really going to penalize you so much, because just as far as you mentioned about blood test, I think as a junior doctor is more than enough for you. But if you didn't specify like what kind of test it is, like there is some specific test and you miss them, it means you cannot reach diagnosis if you don't have any results. And sometimes they have in the exam, they have paper with the results on it, like for example, telling you B12 is this. So they were expecting you to know them, but if you didn't know them, they will not give you the papers with the positive finding. So still you will be left out by not knowing the diagnosis, because from the history alone, we will never be able to tell the patient what exactly you have. So no problem, is still you can pass the station without knowing a specific investigation, without knowing the exact diagnosis. Keep it open and keep it for the senior. You did your best as junior doctors. You have proper history, which was organized, which was relevant, which was not scripted. You was listening to the patient and acknowledging them, and you are not off topic just because you following the patient. You are not following your script, and you showed lots of sympathy and empathy. So please don't forget this. So always try to, whatever the station it is, compensate by these interpersonal skills. Show sympathy, empathy, laugh with them. Seriously try to make them happy, this role player, because when you go out of the room, the examiner will ask the role player, how did you feel about this doctor, as a doctor to you? He said, he's really very nice, I like him. So if they like you, this is marks without anything. They'll give you more marks for all the aspects. So they are not very strict in getting you this 4. For example, if you really very good in your communication skills and you have good history, they will never fail you. They will give you some marks here and there without saying anything, without doing the right things. They will still give you marks. But at the same time, they will not forgive you if you been unsafe and you told the patient about diagnosis that you don't have any proof for it. You don't have any positive blood test. You don't have anything, just from the symptoms. And it means that you know the stations before you came to this exam. And this is something upset them so much to know below 2 stations. So we pretend we never heard about the exam. We don't know it at all. We don't know what the patient have. This is just our patient. We need to deal with it as true patient in the real life. And we be honest with this patient. We tell them what we know and what we don't know. And we are junior doctors. We can refer to senior all the time. Not big deal. But also talking about senior doctors, like James examiner said, some doctors, they refer to senior doctors in all the stations, and below 2 is meant to be in your levels. Like there is nothing difficult to refer to senior here. Like don't make it as like in everything you don't know and just you need to ask. But make effort to answer in a smart way without getting yourself trapped in giving any false information or any false diagnosis or any unconfirmed diagnosis. So just try to make effort to do your bit as junior doctors, explain things from your own knowledge, make it simple, don't distress. Like in the real life, if the patient, for example, has headache and you don't know what exactly causing it. So you will tell the patient like, I'm really not sure at this level what causing your headache. There could be, it could be just a stress headache or from the stress you mentioned. So try to pick something from the history already. Some point he mentioned, so point out them again, like you mentioned you have stress at work. It could be this is the reason for your headache. But also we will do just some further investigation to make sure nothing's sinister, for example, going on. So just be simple. Try to do it exactly as you would do in your real life. And also don't try to exceed your limit as a junior doctor. Never do senior stuff. Like, for example, what senior jobs? Like, yeah, first imaging like CT and this for senior normally in this country. And what else? Discharge for senior. We don't discharge without senior. So if you want to discharge the patient, you have to discuss with seniors. Yeah. And always speak slowly and clearly, and keep like few seconds between words. Like if you speak fast, it for them they will not understand it. So normally English people they speak in my language. When I speak, we don't break, like because we speak too much actually in our language. So we don't break between words, like continuously keep talking. Uh, like English people, they speak slowly, and even if they continued, they will stress in the end of the word. So you know this word is finished, and you're moving to the next word, because English words are not distinct. Like if you speak fast, they will be mixed on each other, and they will not understand you. So always try to speak slowly and word by word, but not too slowly. So it comes with practice, but they're looking for doctors who speak clearly and like because they're checking your communication skills, how you speak, how you communicate with patient. Because mainly junior doctors talk rather than senior doctor prescribe, junior doctor talk in this country. So to talk a lot, like explain to the family, and you will be all the time with directly with the patient and their relatives. So you are expected to talk a lot. So that's why they want you to be good communicator. So always try to speak clearly, and especially in the exam, try to pretend that you're like in Black 2 is same like English exam, or even worse, I guess. They're more strict than OET in your language. So try to make it clear and understandable. And don't speak too much, because when you speak too much, mistakes will happen. Always try to explain a little bit. They're not interested to have a lecture from you, the patient, if they ask you, for example, what is heart failure. So don't try to complicate things. Make it simple and short answers. Don't speak too much, because it will waste your time and they will not increase your marks to spend long time in the same point. They will get 1 point because you explained, for example, what the patient asked you, but it shouldn't be that lengthy. So just make it, for example, if they ask you what heart failure, so don't speak about pathophysiology and what happened to the heart muscle and these things, because the patient even will not understand. So just heart failure is when your heart failed to uh, work in or pump your blood in the right way, and it causes you some symptoms which you mentioned, like difficulty breathing and chest pain, for example. So just you don't need to complicate and speak about pathophysiology and what, just make it, it just causing you the symptoms you're having, and is a condition causing these symptoms and treated by this, for example, and there is medication to help you with this. So because the patient interested about the symptoms they're having, they're interested about the treatment, but they are not interested about the pathophysiology of any disease. So make things simple. All right. Any question? All right, so let's get start practicing. Who wants to do any station?